Hi everyone, I want to talk about heart failure with reduced ejection fraction. And to enjoy heart failure with reduced ejection fraction, I would advise that you kindly check heart failure presentations that I've made on this channel. With that, you'll be able to get a better grasp of heart failure with reduced ejection fraction. So with that, let's go. The heart is failing, and it's failing either because there is impaired filling or impaired ejection. Either way, there is decreased tissue perfusion. Many things are involved, hormonal changes or structural factors, and also the possibility of functional factors. It is either systolic dysfunction, in which case the heart can't contract well, or diastolic dysfunction, when the ventricle can't fill well. Heart failure with reduced ejection fraction is found in left ventricular dysfunction, and it is defined by the value of left ventricular ejection fraction. Normally, in people without heart failure, the value of left ventricular ejection fraction is greater than 50% and could be as high as 70%. Some with heart failure will have the value less than 40% when they have what we call heart failure with reduced ejection fraction. The rest we have what we call heart failure with preserved ejection fraction, and that will be greater than 50% of the left ventricular ejection fraction. I hope you are not being bored by this ejection fraction that I've been repeating. Minimal reduced ejection fraction is found in some people with heart failure, and that means their own value will be between 41 and 49% of the ejection fraction. When the left ventricular ejection fraction is low, it is caused by any factor that causes the heart failure. And left ventricular ejection fraction is used for prognosis. So we use the value of the left ventricular ejection fraction to determine how bad or how fair this heart failure is. It determines the severity. We have been talking about left ventricular dysfunction, and here I have three factors listed that will determine the ventricular function. One, preload. That is the venous return or end-diastolic volume of ventricular filling or initial stretching of the myocytes. Also included will be myocardial contractility. That is the force generated at the end of the diastolic volume. And afterload, which is aortic impedance and wall stress, or the aortic pressure that the ventricle must work against. So all these three factors will determine ventricular function. Medications like epinephrine or norepinephrine will increase intracellular calcium and thereby increasing contractions. Beta blockers will decrease the force length slope, while decreased cardiac output will lead to increased sympathetic activity, and that will in turn increase the heart rate and cardiac output. Also, decreased cardiac output will increase salt and water retention. And when there is salt and water retention, there will be increased blood volume. Increased blood volume will lead to increased diastolic volume and pressure. Treatment of heart failure with reduced ejection fraction. First medication to consider is diuretics, but I will not even go into details of the treatment of heart failure with reduced ejection fraction here right now, because I will make a separate presentation on treatment of heart failure, and that should be out in the next 2 or 3 publications after this. Entresto. Well, I need to make a disclaimer that I'm not the agent of Entresto or selling for them or their marketer. I'm just talking about a good medication. So Entresto contains Vastatin and Cyclobutyrin. That will be very useful here. I've mentioned Entresto the other time when I was talking about brain natriuretic peptides and how it will affect the valve. You can check that out on my channel. Beta blockers, Carfentanil is very good, and you can use metoprolol, ACE inhibitors, nitrate, ivabradine for heart failure with decreased left ventricular ejection fraction less than 35%. If refractory to the treatment mentioned earlier, you can increase your loop diuretics to handle the fluid and add metolazone. You can add or may not spironolactone as well. You should advise the affected individual to reduce fluid intake to about 2 liters per day. Sodium intake should be decreased to 2 to 3 grams per day, and hemodialysis if all measures above fail. If hyponatremic, we can use vasopressin antagonist called tolvaptan. That will improve urine flow without losing much sodium. Isn't that great? Also, I need to make a disclaimer, I'm not selling the drug, I'm just talking about a good one. Don't use it for a long time. Don't use tolvaptan for a long time. And somebody will ask, why that? Don't use more than 30 days because of possible hepatotoxicity. You can have intracardial defibrillator. I'll talk about in a bit when I'll be talking about treatment of heart failure in general. Cardiac transplant or ultrafiltration. Still on treatment, you can also use intravenous vasodilators like nitroprusside, nitroglycerin, intravenous inotropes, because they increase the force of contraction. An example is the butamine if there's decreased blood pressure or there's renal failure. You can use milrinone if there is no hypotension. If there is hypotension, no milrinone plays. You can also get some bioral inotropes like digoxin, left ventricular assist device, or intra-aortic balloon pump. And of course, you can suggest cardiac transplant. Okay, that's it with heart failure with reduced ejection fraction. Kindly subscribe to my channel, and the next presentation will be on heart failure with preserved ejection fraction. Thank you.